Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's very important session, we are going to discuss again the very important questions and concept from the subject that is very much easy, that is very much interesting, and the subject where the sleep will not come while studying that particular subject. Yes. So, in the last session also we have discussed that particular subject, that is the pharmacology. So in this second part of the pharmacology, so I am going to give a best content for you all. Okay. So after this, one more class will go on the pharmacology. Okay. So that is tomorrow. You may get the two classes. Okay. So in the morning one or the evening one or the day after tomorrow, according to my convenience, I will inform you all in the groups. Okay. So I will complete the very important questions before the exams. Okay. So I promise you, I will complete the thing. Yes, it's my responsibility to complete the thing. And very good evening to one and all, and happy Teachers Day to you also. So as a teacher, so we learned more thing, but we learned more than the more thing from the students. Okay, so sometimes we will study more to explain something to the students, right? So if I am talking 10 words in front of you, means I have to prepare for the 100 words. So then only the 10 words will come in front of you. Okay. So for the fear from the students, we will study the more thing, right? So that's what a happy Teachers Day to you all also. Okay. And thank you so much for your unconditional love. Okay. From the whole India, the messages are coming. And my WhatsApp, Instagram, Telegram, everything is filled with the messages. Okay. So for few students, I have given the response, and for few students due to the inconvenience time. Okay, so I am unable to give the response, and I am deeply apologize for the things. Okay, so once again, happy Teachers Day to you all. Okay, so this your unconditional love made me work more towards you people. Okay, so I will give my best shot in this particular session also. A very good evening to one and all, and who all are new to the Master Nursing classes, please do hit the like button and subscribe to the channel. So we will start the session without wasting the time now. Okay, so here will be our first question. So please do read the question. Thank you so much to everyone. Thank you so much to everyone. Okay, so here's the first question. So please do read the question and try to give the best answer for the question. Some small program was there in the home, so that's what the session went late today. So yeah, we will continue now and we will finish it. Don't worry, I promised I will cover all the important pharmacology questions. So definitely I will work on it and I will cover it before your prelims exam. Okay, don't have to worry about that, right? So like here's the first question, an important question for you all. Okay, so according to the American Heart Association Advanced Cardiac Life Support guidelines, okay, what is the recommended initial dose of the atropine for the symptomatic bradycardia in adults? Students, so please do remember, if the bradycardia is there but that is asymptomatic, no need of the treatment. Yes, even if the heart rate is less than 60 and more than 50, okay, in that particular situation, even if it is less than 60 in the adults, okay, no need of the treatment until the symptoms comes. Okay, so please do remember, asymptomatic bradycardia doesn't require any medications. If bradycardia is there, along with that the symptoms will be there. Okay, like hypoperfusion of the vital organs will show the various symptoms in the bradycardia. Okay, so if the symptoms are present, then only treatment required. Okay, so according to the new guidelines of the American Heart Association, what is the dose of the atropine sulfate we need to give in this particular situations of the symptomatic bradycardia? Option A goes here as in the 0.25 mg IV, and option B is the 0.5 mg IV, option C is the 1 mg IV, and option D is the 2 mg IV. Okay, so few days back I posted one slide in your WhatsApp channel that this is the update, please consider. Okay, so it is a question from that update only. Okay, so now give the best answer. Yes, very good. Yes, few of you have given the correct answer. Okay, students, according to old guidelines, it was 0.5 mg IV. Okay, so now new guidelines says it is on the 1 mg IV. So here we have to study the both the guidelines and we will delete the one thing. Okay, so first I will explain you old guidelines of the atropine in the bradycardia. Okay, so old guidelines says 0.5 mg of the atropine. Okay, total 6 doses, and there is 3 to 5 minutes gap between each and every dose. Okay, total how much we will give? We will give the 3 mg. So this was the old concept. Okay, this was the old concept. Now new concept says, okay, according to American Heart Association, okay, now 1 mg, that is 3 doses. Okay, again the gap will be the 3 to 5 minutes gap between the each dose. Okay, so that is maximum we will give the again 3 mg. Okay, so previously we were giving the 0.5 mg 6 doses. Now we are giving the 1 mg 3 doses. Total dose 3 mg, total dose 3 mg. Now this is the old concept. Please don't remember this one. Okay, just you have to remember this particular one and you have to give the best shot in the exam. Okay, so hope it is clear to everyone of you, right? So here comes to the next question, and remember, repeat the dose every 3 to 5 minutes. Okay, so here comes to the golden points on the atropine. Where all we will use the atropine. So please do remember, beta. Atropine is the drug of choice for the adult bradycardia. Okay, so why? Because atropine is on the very important anticholinergic drugs which increases the sympathetic nervous system activity. Whenever there is the increase in the sympathetic nervous system activity, that time the heart rate will increases, right? So in the bradycardia, heart rate was decreasing. Now we are giving the atropine and the heart rate is increasing, and which is coming to normal. So that is the reason in the drug of choice of the bradycardia in the adults goes to the answer, that is the atropine sulfate. Okay, very important. Then comes to the atropine we will give before giving the anesthesia. Okay, so why we will give the atropine before giving the anesthesia? Beta, we are giving the anesthesia means the patients, all the muscles will get weak and paralyzed, right? So in that particular situation, in the oral cavity there will be a production of the mucus will be there. In the nasal cavity there will be a production of the mucus will be there. So we are paralyzing the whole body muscle, means the throat muscles, the pharyngeal muscles, the laryngeal muscles also will get paralyzed. Okay, whatever the secretion it will get producing inside the oral cavity and nasal cavity, that secretions may get land into the trachea, and there may be a risk of the aspiration will be there. In order to prevent that one, we have to reduce the production of the secretion here. Sir, how we have to reduce the production of the secretion? Yes, by giving the drug called as the atropine sulfate, okay, which reduces the production of the secretion. And if any vagal reflexes are happening, means the vagus nerve stimulation is happening, means it will cause the activation of the parasympathetic nervous system. The parasympathetic nervous system, again, if it is activating, means it will cause the bradycardia. Okay, so in order to reduce the vagal reflex or the vagal effect, so again we are giving the drug called as the atropine sulfate. It is very important. Please do remember, the drug of choice for the bradycardia in adult is the atropine sulfate before giving the anesthesia. And very importantly, the question, repeatedly asked question, before giving the ECT, electroconvulsive therapy, in the psychiatry we used to study that one, right? So in the ECT also, yes, before giving the ECT, so we used to give the atropine sulfate again to reduce the secretions from the oral cavity and nasal cavity. Along with that, we in order to act against the vagal reflex. Okay, if the vagus nerve is activating, parasympathetic nerve is activating, bradycardia is happening, means the atropine we are giving means again it will work against that one. The sympathetic nervous system will get activated and it will make the thing balance. Okay, so that is the very important, right? So I told this particular atropine is the anticholinergic drugs, means it increases the parasympathetic nervous system. So pupils will get dilates. Okay, so whenever the parasympathetic nervous system activates, that time pupil will get dilates. So dilation of the pupils we call as the mydriasis. Okay, sir, now ophthalmologist want to assess the posterior part of the retina, means he used to dilate all the pupils, then only he can easily visualize the fundus part of the retina. Okay, if the pupils are constructed, means he is unable to use the ophthalmoscope properly and he is unable to see the posterior portion of the retina, right? So that is the reason before doing the examination of the eyes, so whatever the points I am telling, these points are the points which the examiner will ask you in the exams. Okay, so please do remember, right? Before doing the eye examinations, we have to give the atropine sulfate eye drops we need to instill to the patient. Okay, so atropine sulfate eye drops means which drugs, sir, we will use? The eye drop called as the tropic amide. Okay, so the tropic amide is the eye drop. Tropic means that is the atropine. Okay, it is an atropine derivative, that is the tropic amide is the eye drop we are using to dilate the eyes. Okay, so whenever the eyes are dilated, so examiner means the ophthalmologist can easily visualize the fundus. Okay, so the question will come, before giving the before doing the fundal examination by the ophthalmologist, which of the following drug you need to instill in the eyes of the patient? Option A, epinephrine. Option B, beta blockers. Option C, other drugs. And option D is the atropine sulfate, or the other options like tropicamide they can give. So before doing the fundal examination, we used to instill the atropine derivatives. Okay, so that is to dilate the pupils, that is to make the mydriasis. Okay, so very important, please do consider. Okay, so this particular atropine is also in the antidote for the organophosphorus poisoning, the golden one. Okay, 1000 time asked question. Okay, it is in the 1000 time asked question, the drug of choice for the OP poisoning. Okay, so two drugs we are using. I have the separate question to completely discuss on the OP poisoning and its management. Don't worry, this is the fixed question, so I will discuss that one in perfect. Okay, so don't worry. Now just remember, antidote for the organophosphorus poisoning is the our again atropine sulfate. Very important, right? So it is act as an antidiarrheal also. Okay, rarely we will use, but it will act as the antidiarrheal also. How, sir? How means the sympathetic nervous system activating means the GI system and GI motility. What happens? Yes, in the parasympathetic nervous system activity, GI motility increases. Whenever there is an increase in the sympathetic nervous system, that time the GI motility decreases. The GI motility is decreasing means diarrhea also will get decreases. Okay, so that is the very important thing. Just keep in your mind, which decreases the GI activity. So we can use the atropine sulfate as an antidiarrheal also. Very important. Then comes to suppression of the secretions. Okay, so like all the saliva, sweat, everything, it will get secretions less. So we can use this one before induction of the induction of the anesthesia, and along with that before the ECT. So in order to reduce the salivation, in order to reduce the secretions from the oral and nasal cavity, we will use the atropine sulfate, already discussed point. Okay, if the bladder is over distended or the overactive bladder is hyperactive now. Okay, means bladder will be hyperactive in a situation of the parasympathetic nervous system activity or in case of the cholinergic activity. So now what we have to do here, we have to reduce the parasympathetic nervous system activity and we have to increase the sympathetic nervous system activity. Then only the retained urine inside the bladder will get empty, right? So that is the reason, very importantly, in a overactive bladder, we will give a atropine sulfate. It will reduce the contraction of the uterus, bladder muscle, and it will retain the urine inside only. Okay, so please do remember, in the urine retention case, don't use the atropine. If the bladder is overactive, it is very repeatedly getting empty, so then you can use the atropine sulfate. Okay, so very important, please do remember, which reduces the spasm of the bladder. So this is the golden table, okay, from which there is highest chance of asking the question. Okay, whatever the concept I have explained, so that may comes in front of you as a scenario. Okay, so you are the student of the master nursing classes, you made to solve the scenario questions, because you are master here explaining the every scenario in a very simple way, in a very perfect way. Okay, so is that clear to every one of you? Yes, let me quickly revise the thing. In bradycardia, drug of choice is atropine, because atropine increases the heart rate. In the pre-anesthesia, to reduce the secretion, before giving the ECT to reduce the secretions, we are giving the atropine again. And ophthalmic examination, before doing the eye examination, we are doing the very important, we are dilating the pupil by giving the atropine sulfate, that is the tropicamide eye drops. Okay, so antidote for the organophosphate poisoning. Okay, so which blocks the acetylcholine effect. Okay, acetylcholine effect which is blocking means, yes, the OP poisoning is in the cholinergic poisoning. Okay, that is the poisoning which happens due to the overaction of the acetylcholine. Okay, so here we are blocking the acetylcholine means we can act as in the anticholinergics. Okay, then antidiarrheal, and which suppresses secretion and overactive bladder. So these are the very important things, so please do consider. And other very important points on the atropine sulfate, because one question is fixed, I want to touch the every corner, and I want you people to revise the every corner of the atropine, because it is important. Okay, better please do remember these words: antidote for the mushroom poisoning, antidote for the OP poisoning, and antidote to reverse the cholinergic crisis in the tension test. Better in the case of the myasthenia gravis, we will do one test called as the hydroponium test or the tension test. Okay, in that particular time, there is the highest chance of the patient to get land into the cholinergic crisis. Okay, so in that particular situation, the examiner will ask the question: as a nursing officer, you are assisting a patient who is underwent the who is diagnosed as the myasthenia gravis. Now the doctor wants to do the hydroponium test on the patient. Okay, and he advised to arrange all the necessary medications to perform the hydroponium test. Okay, along with the preparation and keeping the hydroponium ready, which drug you will keep along with the patient? Yes, So we need to keep the atropine sulfate ready, because if the patient is going into the cholinergic crisis, we need to revert back the patient very soon. Okay, so that is the reason while performing the tensilon test or while performing the atropinium test, along with the atropinium, we need to keep the atropine sulfate ready. So please do remember. Okay, so this was the question and this was the scenario they may ask in your exam. Okay, so all the NCLEX points, all the big questions I have made in very simple, and I am creating the scenario and I am explaining because you people can easily grasp the thing in the exam and you can easily give the answer in the exam. Okay, so very important, right? So next I told before the ECT to reduce the secretions, we are giving the again atropine sulfate. Okay, so to dilate the pupils before the fundal examination or before the eye examination, the one drug we are giving here is that one is the atropine. Okay, so very important. Please do remember the a particular thing what I am explaining here. Okay, so next point of the discussion is here. Don't give the atropine less than 0.5 mg. Why? So this was the question here I am asking to you people. So I told in the a very important point that the dose of the atropine in the bradycardia is the 1 mg, 3 doses, 3 to 5 minutes gap, maximum 3 mg, right? So if we are giving the atropine less dose, that is the less than 0.5 means that will again causes the bradycardia. Why? Because it will causes the bradycardia. Already patient in the bradycardia, it will again causes the bradycardia because it is unable to potentially perfectly work there. Okay, in order to attempt the increased heart rate, it will again revert back and it will reduce the heart rate. So if you want to give the atropine, give more than 0.5 mg only. If by mistakenly you are giving the atropine less than 0.5 mg, the patient may get again land into the bradycardia. So please do remember the very important word. Okay, so these are the very important concept on the bradycardia. Here comes to the next question. Okay, so in the last class I told I will discuss all the points on the emergency drugs, especially atropine, adrenaline, okay, and other drugs also. Please do remember the very important scenarios and the questions what I'm explaining to you people. Okay, here comes to the next question. Okay, so please do read the question perfectly and try to mention the correct answer in the comment box. Yes, in a neonatal resuscitation, if intravenous adrenaline is required, what is the recommended dose? So the question is asking from the neonatal resuscitation. Okay, the intravenous, okay, IV route we are administering the epinephrine or the adrenaline, right? So what is the recommended dose which is required here? Option A comes to the 0.01 to the 0.03 mg per kg, and option B comes to the 0.05 to the 0.1 mg per kg. Okay, and option C comes to the 0.5 mg per kg, and option D comes to the 1 mg per kg. Better you can get mg per kg or the ml per kg. So please do understand a thing here. Okay, so that is 0.01 mg per kg. We can write that one as 0.1 mg to 0.1 to 0.3 ml per kg we can write. Okay, so this is the first option. Then the option B, we can write the same option 0.05 to 0.1 mg. We can write this one as in the 0.5 ml to 1 ml per kg. We can write this. Okay, so next comes to the option C 0.5 mg per kg and option D 1 mg per kg. Okay, so now we are giving the IV route of the adrenaline in a case of the neonatal resuscitation. Yes, I already this one covered in the cross course sessions previously. Okay, now again I am explaining to you people because it is important, right? So this particular question is very important. Consider better in the neonatal resuscitation. Very good. Almost all the people given the correct answer. Okay, if the IV route of the medication is required, so the answer goes to the 0.01 to 0.03 mg per kg or 0.1 to 0.3 ml per kg. Both are the same. Both are same. So please do remember this one. Okay, so then comes to the option B. This is the correct answer. Okay, if the IV recommend, okay, if they are asking the IV, okay, if they are asking the intratracheal route, okay, if they are asking the intratracheal route, okay, so in the if they are asking intratracheal route means the our dose should be 0.5 to 0.05 to the 0.1 mg per kg or the 0.5 ml to the 1 ml per kg is our dose in the intratracheal. Okay, so please do focus the mg and ml, so it will get confused you all. Okay, so that is the reason I am explaining here and I am clearing your doubt here. Okay, so you people will not get any confusion in the exam. Okay, so both are same. 0.05 to 0.1 mg is also same, and 0.5 ml to 1 ml is the equal. Okay, so that is the equal. Okay, so very important thing. If they are asking the intratracheal route, so our answer goes to the option B, that was the 0.05 to 0.1 mg per kg. They are asking the intravenous, so I am giving the answer as the correct answer as the 0.01 to 0.03 mg per kg. Okay, so now comes to the option D. So this was the 1 mg. 1 mg is the best drug which is recommended during the adult cardiac arrest. Okay, this was the a dose during the adult cardiac arrest. Okay, so please do remember this one, very important. Okay, so next comes to the in the adult cardiac arrest, in the neonatal resuscitation, already we have discussed the dose. If we are giving the by IV route means, so that was the 0.012 0.03 mg per kg. Okay, so if we are giving the IV route means, so what is the dilution we have to give here? If we are giving IV route means, so the dilution goes to the 1:10,000. So please do remember the dilution here. Okay, so why? Because we are giving the IV route. So which vein is the best here? Which vein is the best here? Yes, the umbilical vein is the best here, because this is the biggest vein and this is the already open vein we are having in the neonate ready, because just we have cut the umbilical cord. Now umbilical vein is easily accessible. Okay, so how much we need to insert the catheter inside? So that is the 7 centimeter we need to insert the catheter in the umbilical vein, so it will directly land that particular catheter into inferior vena cava. Okay, so we can directly contact the heart, okay, by the inferior vena cava. Okay, so that is the very important. Please do remember the recommended vein to administer the epinephrine in the neonatal resuscitation is the umbilical vein. Okay, that's the IV route we are giving with. The dose is 0.01 to 0.03 mg per kg and the dilution is the 1:10,000. If you are giving the epinephrine in the neonatal resuscitation by the intratracheal route means, so I told the dose is 0.05 to 0.1 mg per kg. If you are giving this one by the intratracheal route or the endotracheal route means, so your answer goes to here. The dilution is that is the 1:1000. Okay, so very important. Please do remember this word, it is important, right? Hope it is clear to all of you, right? So here the next question comes to on the neonatal resuscitation and our adrenaline. So when we have to give the adrenaline here in the neonatal resuscitation, better we are doing the resuscitation of the neonate and the heart rate comes to the less than 100 beats per minute. So that time we need to start the bag mask ventilation. Okay, in the neonatal heart rate during the resuscitation, if it is going less than 100 beats per minute means, then we will start the very important bag mask ventilation. Okay, so this bag mask ventilation, it is contraindicated in the case of the, yes, it is contraindicated in the case of the diaphragmatic hernia. So please do remember the bag mask ventilation is contraindicated in the case of the diaphragmatic hernia. Okay, yes, if the heart rate is less than 100 beats per minute, we are giving the bag mask ventilation, and if the heart rate is less than 60 beats per minute means, along with the bag mask ventilation, we are giving the chest compression. Okay, still we have continued this one for the 30 to 60 seconds. Still the heart rate is less than 60 beats per minute only. Okay, still the heart rate is less than 60 beats per minute only, and if it is not recovering, then we will go for the injection epinephrine, and the dose route, everything I have explained you people clearly. Okay, so please do remember the question will comes when we have to start the bag mask ventilation. The bag mask ventilation we need to start, okay, if the heart rate is less than 100 beats per minute. Okay, after stimulation also the patient heart rate is less than 100 beats per minute. Okay, bag mask ventilation we have started. Then the heart rate is less than 60 beats per minute. That time, yes, the bag mask ventilation plus chest compression we have started. still even doing the chest compression and the back mask ventilation, even after perfect ventilation also the heart rate is less than 60 only, and if it is not recovering and we have waited for the 30-60 seconds, still it's not recovering, means we will go for the injection epinephrine. This was the scenario. Okay, so the question will come to you. Okay, how the question will comes? The question will come as the next best step of the management. Sir, how, sir? Yes, you have received a child or the neonate from the labor unit, and after receiving the patient child or the neonate to the NICU, you have kept the child on the monitor. That time you have noticed the heart rate of the baby is uh, less than 100. So what is the next best step of the management? Yes, the next best step of the management is the bag mask ventilation. You have to choose in the option. Okay, yes, in the question they have mentioned the baby's heart rate is less than 60 beats per minute. So what is the next best step of the management? Yes, the next best step of the management is the bag mask ventilation plus the chest compression. So you have received the baby from the labor room in your NICU. Okay, so after newborn, okay, so that newborn now heart rate is less than 60 beats per minute, and the nursing officer have started the bag mask ventilation and the chest compression, and he have performed this for the 60 seconds. Still the heart rate is not improving. So what is the next best step of the management? So this kind of the questions of the next best step of the management they will ask in the exam. So that time your answer should be injection epinephrine. Okay, so all the three scenarios and the expected questions and how the question will arise in the exam I have explained in clear, in perfect, so it will be helpful for you. Okay, so next one here, epinephrine in the adult CPR or in the adult cardiac arrest. Okay, so just the epinephrine what we have discussed, that one we have discussed from the neonatal CPR and the neonatal cardiac arrest. Okay, so now we are discussing here epinephrine in the adult CPR and in the adult cardiac arrest. So what is the dose of the epinephrine according to the advanced cardiac life support, according to the American Heart Association advanced cardiac life support? Okay, so what is the dose of the epinephrine in the adult CPR, in the adult CPR? So this was my question. Yes, the dose is very nice of you. Okay, so that's the 1 mg is the dose we have to give here. Okay, so this is the vial which is having the epinephrine of the, that is 1 mg per 1 ml. Okay, so standard dose it will comes like this, right? Some vial it will come like 0.5 mg for 1 ml. Okay, so if we are requiring a 1 mg means we will take 2 vials. Okay, if the vial is having the 1 ml per 1 mg means, so we will take the 1 vial, so that is the more than sufficient. Okay, the standard dose vials of the epinephrine will come in this particular doses. Okay, so the dose is 1 mg we need to administer here in the adult CPR. Okay, and what is the route of administration here in the adult CPR and the adult cardiac arrest? What is the route of administration of the epinephrine? Yes, well done, beta. So that is the IV is the best route of administration in the epinephrine in the adult CPR. Okay, so what is the dilution? Yes, whenever we are giving the epinephrine in the IV route, always do remember the dilution will be 1:10,000 dilution we will maintain here. Okay, this is the important one. 1:10,000 is the very important one. So please do remember. Sir, how we have to prepare this one? Practical question. Yes, so you have to take 1 mg or the 1 ml of the particular adrenaline, and that one you have to add in the 9 ml of the solution. So it will be a 1:10,000. Already this vial which is having here, so this is the in a ratio of the 1:1000. Okay, if it is in a dose of the 0.1 mg per 1 ml, so if it is in the dose of this one, okay, so that was the already in a ratio of the 1:1000. Okay, so now you have to take 1 ml of the 9 ml of the NS and the 1 ml of the adrenaline. So already automatically the ratio becomes the very importantly 1:10,000. Okay, so this is the very important. So please do remember and keep in your mind. Okay, so here is the next situation based and scenario based questions they will ask in your exam. Okay, so there is the concept based on the shockable rhythm and the non-shockable rhythm. That one you have to keep in your mind. Okay, what is the next best step of the management? This kind of the question will arise here. Okay, so how the question will arise here? Okay, so please do consider. Now the patient suddenly collapses at the washroom of the hospital, and as a nursing officer they have brought a patient from the washroom to the bed. Okay, so when we will assess the cardiac rhythm of the patient, so the patient is in a state of the ventricular fibrillation. Okay, so now the patient is in a state of the ventricular fibrillation and BP has collapsed completely and pulse rate is not recordable. So what is the next best step of the management? Yes, next best step of the management is the CPR. Okay, in that question they are mentioning that the patient is in the state of the ventricular fibrillation and the nursing officer is giving the CPR. So what is the next best step of the management? Beta, if the patient is in the shockable rhythm along with the CPR, the next best step of the management is the defib. Defibrillator we will use here. So that is the very important. Please do consider this one. Okay. In case the patient is in a state of the pulseless ventricular pulseless electrical activity or in a state of the earth systole. So these both are called as the non-shockable rhythm. Okay. The first again here we have to start the CPR along with the CPR in the state of the non-shockable rhythms in the case of the earth systole and in case of the pulseless electrical activity. Okay, along with the CPR we need to immediately give the injection epinephrine as soon as possible. Sir, how many doses we will give, sir? Unlimited dose you can give it. Okay, repeatedly. This particular earth systole, okay, if it is coming to the any kind of the rhythm, so then we will give the defibrillator. Okay, otherwise there is no any use of the defibrillator. So please do remember, in a non-shakable rhythm we are not using the defibrillator. The next best step of the management along with the CPR in case of the earth systole and pulseless electrical activity is the epinephrine. Okay, in the shockable rhythm, that is in the in the PVT and in the VF. Okay, so ventricular fibrillation and the pulseless ventricular tachycardia. Okay, in this both situation. Okay, so in this both the situation, the first answer goes to the along with the CPR. The next answer will be the next best step of the management will be defibrillator. Okay, so this is the very important concept you have to keep in your mind. Okay, so the discussion of this particular question, okay, already I have given and already many times I have given to our student to get practice in the test series also. Okay, so it will be very much important and helpful for you all. Okay, so next a very important question may arise from the epinephrine from the anaphylactic shock. Okay, so this question will be repeatedly asked. Okay, so please do remember the epinephrine is the drug of choice in the anaphylactic shock. Okay, so what is the anaphylactic shock? If any severe allergic reaction happens to the patient, that time all the peripheral vessels will be perfectly dilated. Okay, whatever the volume of the circulation will be there, so that one will get settled into the periphery only, and that particular blood it will not comes to the heart. The blood is not coming return to the heart means the heart is pumping empty only. So empty heart unable to circulate the blood and unable to perfuse the blood to all the vital organs. So if the vital organs are getting the insufficient circulation, so that is what we call as a shock. The shock is happening here due to the severe allergic reaction which made the blood vessels to get completely dilated and all the blood is pooling inside the peripheral veins. Okay, so in that particular situation, okay, we need to give the drug of choice as on the epinephrine. The dosage of the epinephrine in a case of the anaphylactic shock will be, that is the very important. Okay, so please do consider that is the 0.5 mg goes to the correct answer. Okay, so one single best answer is the 0.5 mg. The route of administration is the intramuscular. The route of administration is intramuscular route we have to give. The dilution is whenever we are giving the epinephrine intramuscular, the answer goes to the 1:1000 will be the dilution. So please do remember, okay, route of administration of the epinephrine in case of the anaphylactic shock. So that is the IM. So please don't choose the IV in a anaphylactic shock. The best route of administration of the epinephrine in the anaphylactic shock is the IM. Okay, so the dose will be 0.5 mg and the dilution will be 1:1000. Okay, so the dose ranges from the 0.3 mg to the 0.5 mg. Okay, so best answer goes to the our 0.5 mg, right? So this is the best answer and the single best answer only you have to remember. Okay, so hope all the possible questions from the epinephrine we have discussed here. Epinephrine in the neonatal resuscitation, epinephrine in the very important anaphylactic shock, and epinephrine in the cardiac arrest, and all the next possible and all the next best step of the management. So all the questions we have discussed here in this particular session. Okay, now question comes to you in front of you all. So like this. So please do read the question properly, perfectly, then try to give the best answer for this one. Okay. The question is on the side effect of the beta blockers. Okay. Which of the following is the mechanism by which beta blockers causes the hypoglycemia of the unawareness? So what is the hypoglycemia of the unawareness? For the patient, hypoglycemia is happening, means the blood glucose is decreasing, but there is no sign symptoms are coming, and the patient is not aware about the situation of the hypoglycemia until he will go into the coma. So that is we call that one as the hypoglycemia of unawareness. Okay, hypoglycemia is happening, but patient is unable to show the symptoms because of this beta blockers use. So what is the a mechanism by which the beta blockers is causing the hypoglycemia of the unawareness? Let me explain the concept so you will understand it very easily. Okay, whenever the blood sugar level will decrease, we call that one as the hypoglycemia. Okay, so whenever the hypoglycemia will happen, so that time the patient will show the tachycardia. Okay, patient will show the sweating. Patient will show the anxiety. Patient will be in apprehension. And there is a fine hand tremors. So these are the sign of the hypoglycemia. If you are giving the beta blockers, called as on the lol, okay, all the lols like metoprolol, sotalol, timolol, okay, so this all the beta blockers, okay, so what it will do, it will blocks the beta receptors, okay. When the beta blockers is blocking the beta receptor, means the heart rate will not increase. Why? Because whenever the beta is stimulated, beta receptor stimulated, then only the heart rate will increase. Here we are giving the beta blockers, means heart rate will remains normal only. Yes, hypoglycemia is happening, but heart rate is not increasing, means there is no sign symptoms, there is no palpitation. Okay, heart rate is not increasing means no palpitation, no tachycardia symptoms. Okay, so hypoglycemia happening, sign symptom not coming, hypoglycemia of the unawareness. Okay, similarly, when we will give the beta blockers, the anxiety will not happen easily, sweating will not happen easily, apprehensions, tremors will not happen easily. Okay, that is the reason beta blockers will never ever give along with the hypoglycemic agents. Okay, so before beta blockers plus insulin should not be given. Okay, beta blockers with metformin should not be given. Beta blockers with glyburide should not be given. The main point of the discussion is here, whenever you are giving the oral hypoglycemic agent or the subcutaneous insulin, so that time don't give beta blockers, because if the patient is going into the hypoglycemia, means the patient is unable to show the symptoms. So that is what we call as the hypoglycemia of the unawareness. Okay, so how it is doing the hypoglycemia of the unawareness? Yes, almost all people given the correct answer for this question. Okay, so that is the blocking the adrenergic symptoms. Okay, all the symptoms which is like tachycardia, apprehension, anxiety, tremors. Okay, so these are the adrenergic symptoms. Okay, and palpitation. So here the beta blockers are blocking all the adrenergic symptoms such as the tremors, sweating, everything it is blocking. So the patient is unable to experience the symptoms of the hypoglycemia. So we call that one is the hypoglycemia of the unawareness. So which happens whenever we will give the beta blockers along with the oral hypoglycemic agents or along with the injectable subcutaneous insulins. Okay, so that is the reason along with the insulin don't give the beta blockers, along with the metformin, glyburide, okay, and the glimepiride, whatever the oral hypoglycemic agents you are giving, along with that don't give the beta blockers. So this was the concept you have to keep in your mind. Okay, so very important. Next comes to the question of the discussion here. Okay, so in the today's class we will experience the all the explain like scenario based like questions. Okay, it was actually a very easy questions. Okay, so next point of the discussion is here. Okay, so that is we have already discussed on the atropine. Okay, if the atropine is getting failed in this particular situation, what is the next best step of the management? So again the question is here. Okay, a 60-year-old male parents present to the emergency room after the accidental exposure to the organophosphorus insecticides. Okay, so please do remember this organophosphorus will be there, which is ingredient of the all the insecticides chemicals where we our farmers using in the in his own field. Okay, so whenever the farmers will use the insecticides, that time due to the some air, so due to the some exposure to that particular chemical directly on the skin, on the eyes, on the oral cavity, on the mucus. Okay, so the organophosphorus, it will get enters into the body. Okay, so the active chemical inside is the organophosphorus is the malathion. Okay, so that is the malathion. Okay, so this malathion is the very dangerous chemical, right? So this malathion is in the a very important and very dangerous chemical. It will increase the cholinergic poisoning. Okay, it will cause the cholinergic poisoning. So that is the reason whenever a farmer he will comes to the emergency department with history of the insecticide use, so always think about the OP poisoning. Okay, so this scenario only, this situation only will created in front of you in the exams. Okay, so the organophosphorus insecticide chemical, so that is the a chemical used by the farmers in their field. Okay, along with that a history of the use of the insecticides. Okay, if there is a sign symptoms of the cholinergic poisoning, for example overproduction of the saliva from the mouth, pinpoint pupils, bradycardia, diarrhea and hyperactive bowel sounds. So these all are the sign symptoms which happens due to the organophosphorus poisoning or due to the cholinergic poisoning. Okay, so that time his symptoms are like meiosis, that is the parasympathetic symptom. Okay, so meiosis means the pupil will be constricted or the pinpoint pupil we can say, and the bradycardia, heart rate will decreases, excessive secretions of the saliva. Okay, so along with that, even it is after administering the atropine, vital signs just stabilized, but his muscles remains weak here. Okay, and patient is having the ongoing respiratory distress. So what is the additional therapy would be indicated here? Yes, the patient is in the OP poisoning and the symptoms of the parasympathetic poisoning or the cholinergic poisoning has started here. There is the meiosis, bradycardia, excessive secretion. Okay, after administering the atropine sulfate, his vitals are get stable, but he remains weak and ongoing respiratory distress is there. What is the additional therapy would be indicated here? Yes, option A comes to the administer the naloxone, but naloxone is the antidote for the opioid poisoning. It is not for the OP poisoning. It is not for the organophosphorus poisoning. Naloxone is the antidote for the opioids poisoning. So please do remember, right? Don't confuse in the exam. Okay, so don't OP poisoning you will see. Yes, opioid somewhere we have studied and first option we have studied and we have marked the first answer as the correct answer. But after coming to the exam, okay, you will see the same questions which have came in your exam in our master nursing classes question discussion. Okay, sir, it was actually that one, this one you will make a simple mistakes. Okay, that is the reason whenever you are attending the every test series, please do read the all the options. Even if you know the correct answer, so please try to practice yourself to read the all the option. Okay, that will help you to reduce the mistakes, unnecessary mistakes. Okay, so next comes to the option B, administer the activated charcoal. But activated charcoal is the universal antidote we can use anywhere, but here the patient is in a situation of the respiratory distress and he's remain weak. So we want the patient to get muscles to get strong and his sympathetic nervous system to get more work. Okay, so that is the reason I will give the one more anticholinergic drugs along with the atropine. That is the pralidoxime. That is the 2-palm we can say, or the pralidoxime. This was the drug of choice. So we will give, if the atropine fails in the OP poisoning management, so the next drug we are giving is the pralidoxime. And some new FDA means the Food and Drug Administration authorities, they recommend that you can give the atropine and the pralidoxime together to a patient with the organophosphate poisoning. Okay, so that is the very important. So please do remember the point of the discussion here. And I have cleared the situation of the farmer organophosphate poisoning and insecticides history and the symptoms of the OP poisoning or the cholinergic poisoning, that is the pinpoint pupil, bradycardia, excessive secretions and hyperactive bowels. And along with that, I have discussed the management. That is the we have to do the very important here, the atropine sulfate as the drug of choice. Even after giving the atropine sulfate, the patient is not recovering properly and still the respiratory distress and the weakness is there, means that time we will give the pralidoxime as the a very important drug of choice. Okay, so that is the very important. So please do consider in your mind. Okay, so next here, what is the role of the carbidopa when administering with levodopa in the treatment of the Parkinson's disease? In the treatment of the Parkinson's disease, Okay, so what is the role of the carbidopa when we will administer with the levodopa in the treatment of the Parkinson's disease? Okay, so let me explain all the very important golden points on the Parkinson's disease. Parkinson's disease is a, yes, what happens in the Parkinson's disease? In the Parkinson's disease, there is a dopamine deficiency. Okay, so there is the dopamine deficiency. Where there is the deficiency of the dopamine is deficient in the brain. Okay, so my purpose of the treatment is to increase the dopamine in brain. Okay, I want to increase the dopamine in the brain, so this is my purpose of the treatment. But what happening here, whenever I will give a levodopa drug, okay, so this one, it will get converted into the dopa and it will enter into the blood. Okay, it will in the blood. Okay, in the blood, what happens? This levodopa will get converted into the dopa. Okay, so this dopa, with the help of the peripheral decarboxylase enzyme, it will get converted into the dopamine in the periphery only, because it is the peripheral decarboxylase enzyme. Okay, so this is the blood-brain barrier we have. Okay, so this particular dopa is having the ability to cross this blood-brain barrier. Okay, and this dopamine, it won't cross the blood-brain barrier and it will get eliminated and it will get excreted from the body. Okay, so this was the brain, where in the Parkinson disease, actually the dopamine we want in the brain, but this levodopa we are giving, this levodopa is get converted into dopa, and this dopa, with the help of the peripheral decarboxylase enzyme, will get converted into the dopamine and it is getting eliminating from the body without going to the brain. Okay, so that is the reason, along with the levodopa, I will give the drug called as the carbidopa. Okay, I will give the drug called as the carbidopa. This carbidopa, it will blocks the peripheral decarboxylase enzyme. Okay, so this dopa, it will not get converted into the dopamine. Okay, and this dopa, it will get enter into the brain now. Okay, so along with that, this carbidopa, it will blocks the peripheral decarboxylase enzyme and it will again stimulate the central decarboxylase enzyme. Okay, which is there in the brain. So in the brain, this particular dopa, it is get converting into the dopamine. It will get converting into the dopamine, and our purpose of the treatment was to increase the dopamine in the brain. So now we are giving the carbidopa, which is blocking the peripheral decarboxylase enzyme, and it is not getting converting into the dopamine in the periphery. Okay, so this dopa is entering into the brain, and in the dopa in the brain, it is getting converting into the dopamine, and in the brain there is availability of the dopamine is there. So this is how, very importantly, our carbidopa helps to a peripheral conversion prevention. It will be done by the carbidopa. Okay, let's come to the question discussion. Option A, a carbidopa increases the central nervous system penetration of the levodopa. Beta, it may performs, but it is not in the direct mechanism of the our carbidopa. Then comes to the option B, carbidopa prevents the peripheral conversion of the levodopa into the dopamine. Yes, so this is the main function what the carbidopa is doing here. Okay, carbidopa is preventing the peripheral conversion of the levodopa into the dopamine. So this goes to the correct answer, right? Then comes to the option C, carbidopa acts as the dopamine receptor agonist. No, it is not acting as any agonist. Okay, and carbidopa decreases the metabolism of the levodopa in the brain. No, beta, it will increases the mechanism of it is increases the metabolism of the levodopa in the brain. It is not decreasing. Okay, so my answer goes to the particular question goes to the our option B. So carbidopa, which prevents the peripheral conversion of the levodopa to dopamine. Okay, so this is the correct answer, right? So please do remember the concept. Okay, so the next question is here in front of you. So please do read the question carefully, properly, then try to give the best answer. Which of the following drug is contraindicated in the patient with glaucoma? In a patient with glaucoma. So what is the glaucoma? Yesterday only we have discussed the glaucoma is the increase in the intraocular pressure. Okay, inside the eyes. Okay, so due to the excessive production of the aqueous humor or due to the blockage of the trabecular meshwork. Okay, so what is the normal intraocular pressure we have? Yes, what is the normal intraocular pressure we have? We have discussed in the yesterday class. That is the 10 to 21 mm of Hg is the normal intraocular pressure. If intraocular pressure is going more than 21 mm of Hg, so we will call this one as the increased IOP. Okay, in the increased IOP, there is chance of the damage to the optic nerve and there is the permanent blindness may can happens. Okay, so they are very very important. Please do remember. So which drug we are not giving, or which of the following drug is contraindicated in the patient with the glaucoma? Beta. So please do remember. I told the atropine sulfate, the anticholinergic drugs, which is having the potentiality to cause the dilation of the pupils. Okay, it will do the pupil dilation. Whenever the pupil will get dilated, that time the trabecular meshwork will get constrict and it will get blocked. Okay, the angle will get blocked. So that is the reason the atropine sulfate or the anticholinergics, all the drugs or any drugs which will dilating the pupils are contraindicated in a patient with the glaucoma. Okay, so why it is contraindicated? Understand, in yesterday class only we have discussed. So this is our beautiful cornea. Okay, so this is our outer layer of the eye. So that is our sclera. Okay, and here we have the pupils. Right, here we have the pupils, and this is our eval body. This is the choroid, the middle layer of the eye, the choroid, middle layer of the eye, and here inside we have the retina. Right, this is the retina, the inner layer of the eye. Okay, so here the suspensor ligaments which holding the lens. Okay, in the place. Right, so this is the lens in the place. In this particular area we have the mesh like structure, we call that one as the trabecular meshwork. From here the aqueous humor is production and it is coming here, and in this particular mesh like structure it is observing. So this is what we call the trabecular meshwork, and here will be angle, here will be an angle. So this angle, if this particular pupils, these are the pupils. Okay, this black color protruded part are the pupils here. Okay, if this particular pupils it get constrict means, then pupil is constricting means, sorry, the iris muscle is constricting means this gap is the pupil. Okay, so if this iris muscle is constricting means the pupil will get dilated. Okay, if this iris muscle is getting not contracting means that time the pupils will get constrict. Okay, so iris muscle constricting, pupil will dilate. Okay, so what is the pupil? Pupil is the gap between the two iris muscle. Okay, so this gap between the two iris muscle we call this one as the pupil. Okay, so this particular iris muscle it is getting contract. Okay, how it is getting contract? It becomes this much in the length. Okay, only this much in the length means the pupil will get dilate like this. Okay, so that time this iris muscle which is constricting means it will block this angle. Okay, if the angle is blocking means there is no absorption of the aqueous humor. The aqueous humor is not observing means again there is in the increased aqueous humor in the anterior chamber of the eye. Okay, again which will increase the intraocular pressure. Okay, again increasing the intraocular pressure means again the risk of the glaucoma increases. So that is the reason all the anticholinergic drugs which will dilate the pupils means it will constrict this particular iris muscle. Okay, so that is the reason all the drugs which will constrict the iris muscle or which will dilate the pupil we will not give in the case of the glaucoma. Okay, so please do remember the golden word atropine sulfate. Atropine sulfate or the atropine is the drug clearly contraindicated in glaucoma. Very very important. Okay, why? Because it will cause the pupils to get dilate and iris muscles to get constrict and it will block the angle. Okay, so that is the point of the discussion, right? So that is the reason all the anticholinergics are contraindicated in the case of the glaucoma. Okay, so what are the drugs we will use the glaucoma? Beta, the carbonic anhydrase inhibitors. Okay, in this one we are using the drug called as the acetazolamide. So this acetazolamide it will decrease the production of the aqueous humor. So we can use this one as in the best drug in the treatment of the glaucoma. Okay, next comes to the beta blockers. Beta blockers, what it will do? It will constrict the pupil. It will constrict the pupil. It means the angle is opening. The angle is opening means we can use the beta blockers in a situation called as the glaucoma. Okay, the best beta blocker for the glaucoma is the timolol. Okay, so timolol is the best what we can say drug in the management of the glaucoma. Okay, so next comes to the alpha agonist. Okay, all the alpha agonist drugs so we will use again in the treatment of the glaucoma because this alpha agonist drugs also will increase the and which will dilate the it will constrict the pupils and it will dilate the or it will relax the iris muscle and angle become open here. Okay, So that is the reason in the alpha agonist also, like bremonide we will use, and the timolol as the beta blocker we will use, and astazolamide as the best carbonic anhydrase inhibitor we will use in the treatment of the glaucoma. And these particular anticholinergic drugs like atropine sulfate and its derivatives like tropicamide and all we will not use in the treatment of the glaucoma, and it is clearly contraindicated in the glaucoma. So this question is the very important question. Okay, this may directly strike in your exam. Okay, so please do remember. Okay, very important, especially atropine we will not use in the treatment of the glaucoma. Okay, so hope the particular concept is very much clear to every one of you. And here is the some assignment question, so please do remember. Okay, and you have to mention the correct answer in the comment box at the end of this video. Okay, so best route of adrenaline in anaphylactic shock. In anaphylactic shock. Yes, that is the which route is that one. Okay, so the next one. How adrenaline work in anaphylactic reaction, whether by vasoconstricting, whether by peripheral vasoconstriction or by the peripheral vasodilation. Yes, how it will helps in the treatment of the anaphylactic shock. Option A, peripheral vasoconstriction. Option B, so that is the peripheral vasodilation. So what is the correct answer for this question? So please do comment answer in the comment box. Okay, so in the tomorrow morning session again the one more session will be there on the pharmacology. So that is the final session on the pharmacology. Okay, so don't forget to join in the next class. The time schedule again I will inform in the group. So stay connected, stay motivated. So today was the program, so that's what the class duration was somewhat less. So again I will give my best shot in the next class, and I will try to complete the entire pharmacology. Okay, so thank you so much for watching the video till the end. Okay, so and once again happy Teachers Day to every one of you, and love your teachers. Okay, so try to irritate them how much it is possible to get the knowledge. Okay, not unnecessarily. Okay, so yes, thank you so much for watching the video till the end. And if you are new to the Master Nursing Classes YouTube channel, so don't forget to subscribe to the channel, and if possible, so please do share the particular video into your WhatsApp status, so that will help us to grow more, and that will help us to grow together. Okay, that will help us to get motivated more. Okay, and one more important announcement to every one of you. Okay, so daily free live exam is going on at the all India level for the all the Norcet aspirants. Okay, in the Master Nursing Classes app. So the link of the app I have given in the description box. You can download that one and attend the Norcet free exam till your Norcet prelims exam. Okay, so that is every day the exam is free of cost. You can attend and you can assess your level of the preparation, and all the important questions I am included in the test series. Okay, so that is the very important. You must need to practice, and you should need to practice. Those questions are there in the our test series. Okay, if you want, you can join the series. Okay, so I have given the link in the description box. That is the free of cost. Again, I am telling there is no need to pay any single rupees. Just open the Super 60, click on the live. Okay, click on the attempt and attempt the paper and analyze your rank. Okay, at the 11:30 p.m. we will announce the all India rank to every one of you in our WhatsApp group. Okay, so thank you so much for watching the class till then. We will meet again in the tomorrow session. Tab tak ke liye, bye bye, take care, love you, all the best.